Okay, we are running live now. So, good evening, everybody, and welcome to this monthly MedEClasses postgraduate lecture series in which we are going to talk about a very important topic of hypokalemia. This lecture series, as we've discussed earlier, is an event which we organize monthly, and we propose to have 36 such sessions covering the entirety of postgraduate relevant pediatric endocrinology. So we have been running on electrolytes for these last few sessions. We're on hyponatremia, hypernatremia, and today we talk about hypokalemia. Now, hypokalemia is very common in terms of pediatric practice, but Dr. Manoj, what do you think are the major causes? So today I am joined by Dr. Manoj Agarwal and Dr. Vibha Yadav, who are fellows in pediatric endocrinology, who will be part of this program. So Dr. Manoj, what do you think in terms of from a pediatrician's perspective, how common are endocrine causes of hypokalemia?
So, if we talk about the pediatric perspective, then the diarrhea and vomiting is major cause of the hypokalemia. So, it is a normal in the for the pediatric, but we have to keep our eye and ear open to not miss the sinister pathology like RAS axis or tubulopathy or the Bartter or Jitterman syndrome, because this can cause the persistent and the chronic hypokalemia. So, identifying etiology is a very major cause in this particular concern.
So, Dr. Vibha, what do you think are the pointers when somebody should start thinking that, okay, this is not a simple cause of hypokalemia, we are thinking of some form of a endocrine cause of hypokalemia?
Like when any patient comes with like a failure to thrive, not gaining weight, and having like malnutrition and having multiple fractures, like in the case of RTA, it could be the cause of one of the hypokalemia, and we should not miss it because it would lead to very life-threatening complications of metabolic acidosis. And another another symptoms could be like paralytic ileus or having this could be many problems.
What would you look at in terms of hemodynamic status, which will tell you the likelihood of an endocrine cause? Which parameter you will look at?
So for the hypokalemia, there will be for the ECG you are talking about?
No. So I'm talking about what will be the pointer that this is an endocrine cause. So if this thing is high, you start thinking this is an endocrine.
Sir. Basically, BP. We will look for the BP. If it is high, then definitely there is the RAS axis. It is involved here. And
yes. So as Dr. Manoj and Dr. Vibha have said that the hypokalemia is very common in pediatric practice. We talked about hyponatremia. It is also common, but there are much more endocrine contribution, particularly of SIADH. Hypernatremia, which we discussed in the last session, is usually because of dehydration, or a chronic hypernatremia would basically is equivalent to diabetes insipidus. This is what we discussed. But when we talk about hypokalemia, there are many more acute causes. You may have a gastrointestinal loss, you may have diuretic use, you may have urinary loss, which will be more common. But if you have chronic hypokalemia with hypertension, along with that severe failure to thrive and polyuria, you start thinking of tubulopathies and endocrine causes which may become relevant from that perspective. So we'll be starting the session. We'll talk initially about pathophysiology. Then Dr. Manoj will talk about etiology, followed by assessment and management by me. And Dr. Vibha has collated a number of interesting questions which are relevant from postgraduate perspective, which can come from that perspective. So as we have discussed, hypokalemia is a common finding, but often it becomes like a diagnostic challenge, which is there in that perspective. So one needs to be aware and open to the various possibilities which are there. So we had this 2-year-old boy who presented with failure to thrive and had a significant failure to thrive in the form of weight of only 8 kilograms and compromised height with hypokalemia. Now, based upon the workup, and we'll discuss subsequently as to how blood gas becomes very important in here in terms of evaluation, the patient had alkalosis, which was quite significant, and further workup showed a normal blood pressure. Along with that, a hypocalciuric situation and a low magnesium. So we had a child who has hypomagnesemia with failure to thrive with hypocalciuria. The most common diagnosis people make is that of Jitterman syndrome. But the challenge in the evaluation of hypokalemia is not to rush towards unusual causes, because common causes are more important. So what we should consider here was to look at malnutrition. So when we looked at the fractional excretion of magnesium, which was low, it suggested that this was primarily a cause of malnutrition causing hypokalemia rather than a tubulopathy. So we need to have a comprehensive assessment with regards to the evaluation before we reach to a particular cause, because that cause deserves a specific treatment in that perspective. So as discussed, we'll touch base about pathophysiology, followed by criteria and etiology, management, and then we'll go forward from that perspective. All of you can go and have a look at our website, learning.growthsociety.in, which has got validated modules with regards to different aspects of pediatric endocrinology. We have got our e-learning portal on YouTube, where now there are a large number of videos, and you can also access our courses, which provide validated tools for assessment and evaluation. We have specific courses in the form of fellowship in pediatric endocrinology and pediatric endocrinology for postgraduates, cater to specific needs of people at different levels of careers. We do conduct 3 programs on a regular basis in the form of a pediatric endocrine grand round, a pediatric endocrine focus discussion, and this PG lecture series, which cover entirety, and these are available routinely on Zoom and YouTube. All the recordings are there. There are 2 publications which are available through our website, as well as the Kindle book reader and a mobile application, which helps in terms of assessment and diagnosis in that perspective. So starting about potassium homeostasis, we need to understand that there are 3 major components which regulate the potassium status. One, of course, is the intestinal absorption and the renal excretion. But the third major factor is also the intracellular component. So we need to understand that as against sodium, when we talked about hyponatremia and hypernatremia, which is mainly a extracellular ion, potassium has got a huge resource which is there inside. So fluxes which happen between the intracellular and the extracellular compartment do have a significant role in acute changes in terms of potassium. So if we talk in a very simplistic manner, the acute changes in potassium would usually be because of an intracellular shift. So we have some mechanism by which potassium goes into the cell that will cause a severe hypokalemia in the form of a channelopathy, in the form of insulin excess, in the form of metabolic alkalosis. Chronic hypokalemia would require a decreased intake or a gastrointestinal loss, but most importantly, urinary loss of potassium. One thing to remember is that unless we have increased urinary loss, the body will be able to compensate the potassium level. So if you have hypokalemia, it means that there is an increased urinary loss of potassium, and that is largely driven by the renin, angiotensin, aldosterone system. So as we discussed in hyponatremia, any patient who has got a chronic hyponatremia has an excess of AVP, whether it is appropriate or inappropriate. Any patient with chronic hypokalemia will have an excess of the renin, angiotensin, aldosterone system, whether it is primary, which is a pathological cause, or secondary, a compensation to hypokalemia. So RAS excess is fundamental to hypokalemia, and this is something which is very, very important to understand in that perspective. Now, we have discussed clearly that potassium is largely an intracellular ion. There is a 40 times more concentration within the cell as against the extracellular compartment. And there is an elaborate mechanism. A lot of energy is spent by the body to ensure that potassium is in the cell and sodium stays outside. And that is done through the sodium potassium ATPase, which requires a lot of ATP, exchanging sodium outside and getting potassium inside. Agents which increase the sodium potassium ATPase activity, namely insulin, beta agonists, can cause sudden onset hypokalemia. And insulin is particularly important in the setting of treatment of diabetic ketoacidosis. Now, we all know that in DKA, there is a significant amount of potassium loss to the tune of 4 to 6 millimoles per kg. But most of this loss is compensated by the efflux of potassium from the cell outside because of insulin deficiency, acidosis, and other parameters. Now, as soon as you give insulin, as soon as you correct acidosis, this potassium goes into the cells, causing a significant hypokalemia. Similarly, in malnourished individuals who have a sudden recovery, or we are doing too much overfeeding, will result in an increased insulin release, which will cause potassium to go inside, causing hypokalemia of refeeding. So insulin plays an important role in the cellular efflux mechanism of this regards. The other intracellular ions include magnesium and phosphorus. And one key principle which we need to understand is that if you have deficiency of one intracellular ion, there is a deficiency of the other as well. So if you have hypomagnesemia, you will also have hypophosphatemia and hypokalemia. Similarly, if you have hypokalemia, you will also have hypomagnesemia and hypophosphatemia. So in simple terms, if you have chronic hypokalemia, like if you have chronic hypocalcemia, do go and measure magnesium level as we showed in the first case in that perspective, and that becomes important. Now, we need to understand a bit, as we talked about, there are three major components: the cellular exchange, the intestine, and the kidneys. So within the intestine, we need to understand that potassium is basically secreted a large amount in the lower secretion, and where you also have bicarbonate. So if you have excessive loss because of diarrhea or lower gastrointestinal tract, you will have acidosis. While if you're having vomiting, you will be losing a lot of acid, which will result in hypokalemic alkalosis. So the basic difference between hypokalemia because of the upper GI loss is that it is associated with alkalosis, while if you have a lower gastrointestinal loss, you will have acidosis. Now, this relation of potassium and proton is also very important. We need to understand that there is a competition between potassium and proton, both for going inside the cell as well as being lost in the urine. So if you have hypokalemia, generally there will be alkalosis as a normal response, because if you have hypokalemia, the body will be losing a lot of proton. It will like to conserve potassium, and therefore in that conservation process, it will lose proton. And this is what we'll discuss about when we talk about renal homeostasis. So generally speaking, if somebody has hypokalemia, they will have alkalosis. If somebody has hypokalemia with acidosis, there are very limited causes, broadly two causes: lower gastrointestinal loss or renal tubular acidosis. So the most important investigation to look at in a child who has chronic hypokalemia is the blood gas, because it gives you the diagnosis right away in that perspective. Now, whether you have a vomiting or whether you have a diarrhea, your volume will come down, and this volume is going to trigger the renin, angiotensin, aldosterone system, which will then cause potassium loss and sustain the level of hypokalemia. If you do not have dehydration or the RAS axis is not activated, you would not anticipate to have this persistent hypokalemia. So as discussed initially, to have a sustained hypokalemia, you require a RAS excess, whether it is a primary phenomena or a secondary phenomena in that regards. Now, coming on to the third most important aspect of potassium handling, that's the renal system. So we all know that potassium is freely filtered in the glomeruli, and it's all reabsorbed in the proximal tubule. So whatever potassium we get actually comes from the collecting duct, and this is an important concept to understand, and this happens in exchange to sodium. So the epithelial sodium chloride channel, which basically is there in the collecting duct, will cause a migration of sodium or an efflux of sodium along with chloride. The passage of sodium is quick, chloride goes a bit slowly. So this creates an electronegative environment in the lumen, and this will then drag all the positive ions which are there to be lost in the urine. So if you have increased sodium delivery in the distal region in the form of increased salt intake, in the form of diuretics, or if you have increased RAS activity or absorption or the activity of the epithelial sodium chloride channel, you would be absorbing more sodium, you will be losing potassium. So any condition in which you're taking too much salt, there is a RAS axis, there is an epithelial sodium chloride channel activity, which is more, this will be associated with significant hypokalemia. Now, other positive ions which will also be lost will include the proton, and along with that, you will have a loss of ammonia in that perspective. So if you talk in that perspective, when you're losing potassium, you're losing proton as well. So there's an association of hypokalemia and metabolic alkalosis in that regards. So if somebody is having loop diuretic or osmotic diuretics, the sodium concentration in the distal area of the tubule, the collecting duct, becomes more, and you will have more sodium loss, resulting in a compensatory hypokalemia in that setting, and this becomes relevant in that regards. Now, the whole process is largely regulated by the renin, angiotensin, aldosterone system. So we all know that the kidneys, the JG cells, particularly based upon the potassium level of hyperkalemia and hypovolemia, secrete renin, which converts angiotensinogen to angiotensin 1, which is converted peripherally largely in the lungs using the angiotensin converting enzyme to angiotensin 2, which then stimulates aldosterone production. So if somebody has hyperkalemia or hypovolemia, the aldosterone levels will go up and this will cause potassium loss. So hypovolemia, therefore, is an important stimulus of potassium loss causing hypokalemia in that scenario. So within these three organ models of a cellular shift, gastrointestinal loss, and the renal loss, we can now consider the pathophysiology or etiology of hypokalemia. If somebody is taking less amount of potassium, it's very unlikely to develop hypokalemia. But if there is associated hypomagnesemia, and as I said, if you have hypomagnesemia, the renin, angiotensin, aldosterone system will go up, and any intracellular loss of one ion will cause loss of others. It will cause significant hypokalemia in that scenario. Intracellular shift will be relevant during insulin treatment or alkalosis, the use of beta agonists, and particularly intramuscular chloroquine, and that could be a lethal form in that perspective. And of course, channelopathies in which suddenly the channels open up and the potassium goes out in that perspective. Intestinal loss can happen with the setting of diarrhea, where you have associated acidosis, or vomiting, where you have associated alkalosis in that scenario. NG aspiration will also behave like upper tract loss with hypokalemic alkalosis. The renal loss will be, the important cause will include metabolic alkalosis. So hypokalemia causes alkalosis, alkalosis causes hypokalemia. Tubulopathies like Bartter and Gentleman syndrome, loop diuretics, and of course, excess of the renin, angiotensin, aldosterone system, hyperrenism, renal artery stenosis, aldosterone producing tumor, epithelial sodium chloride channel defect in the form of Liddle syndrome, they will all cause abnormalities in that regards. So from an etiological perspective, hypokalemia can be because of cellular shift. These are acute causes, insulin beta agonist, periodic paralysis, and add risperidone in that perspective, or an extra-renal cause in which you have got a urinary potassium which is low, which includes a GI tract abnormalities like vomiting or NG aspiration, or rarely cystic fibrosis. Or finally, the most common cause ultimately is a urinary loss where the urinary potassium is high. This could be a RAS-dependent process with hypertension, including aldosteronism, in which aldosterone levels will be high, Liddle syndrome, which is basically epithelial sodium chloride channel activation, or CH variants in which you have got increased upper and mineralocorticoid activity. These are associated with low levels of aldosterone. Finally, you may have a scenario which is RAS independent, which includes tubulopathy, which is associated with alkalosis, and renal tubular acidosis, which is associated with acidosis. So if we talk about hypokalemia, we need to first understand whether there is a cellular shift or not. If the shift is not there, look at urinary potassium. If it's low, we're talking about gastrointestinal or extra-renal loss. If there's a urinary loss, if there is hypertension, we are talking about a RAS-dependent causes. If there is no hypertension, do a blood gas. Blood gas shows you alkalosis, it's tubulopathy. Acidosis will mean renal tubular acidosis. So most important investigations in anybody with hypokalemia, and this I'll connect later on, include the blood gas and the urinary potassium and the measurement of blood pressure. These three will give you a classical diagnosis at that point of time. So now we will have the second presentation on the etiological aspects. So Dr. Manoj, you can now share the screen and start the presentation.
Is my screen is visible now?
Yes, it is visible.
Okay, so now first of all, I would like to thanks to Dr. Anurag sir for giving such an opportunity to speak in this kind of platform. And second, I want to congratulate because conducting such kind of wonderful series for the post-graduation students. So now if we will move towards the etiology, then as sir very well explained that why hypokalemia occurred, now we will see in the details. So in the diarrhea, there is a high amount of the potassium in the diarrheal fluid, like it is a 20 to 50 millimole per liter. So any cause of the diarrhea directly can cause the hypokalemia. Secondary, if we talk about the vomiting, then vomiting has a lower amount of the potassium than the diarrheal fluid, like 5 to 10 millimole per liter. So it can't cause directly hypokalemia, but due to the excessive acid loss, there will be the alkalosis which trigger the RAS excess, and due to the volume contraction, there will be the RAS activation, and this RAS activation cause potassium loss from the body. But in this particular condition, urinary chloride and potassium will be less than 20 millimole per liter. So in the general pediatric OPD, these are the main causes of the hypokalemia, mainly due to the diarrhea, and vomiting cause the hypokalemia due to the alkalosis and due to the volume loss. So now we will move towards the another entity which is a very important, which is the RAS excess and which cause the chronic persistent hypokalemia. So what are the causes for it? So any causes for RAS activation or RAS excess cause hypokalemia, like renal artery stenosis, which cause the hyperenism, which cause the hypokalemia, aldosterone producing tumor like adenoma, hyperplasia, or glucocorticoid remediable aldosterone, where ACTH is working on the aldosterone, where the hypokalemia is more likely. And finally, into the third category, if there is a Cushing syndrome, where the excessive cortisol is also working on the aldosterone receptor, it causes the hypokalemia. AME, Liddle syndrome, and CH, like 11 hydroxylase deficiency and 17 hydroxylase deficiency, also cause hypokalemia. So now we will discuss each and every entity in the details. So if we move toward the adrenal adenoma simply means it is a aldosterone producing tumor. What does that mean? There will be the excessive amount of the aldosterone production from the body. So there will be the excessive amount of the aldosterone production. It mainly, patient may present with the hypertension mainly, and there will be the hypokalemia is very less. So only 20 to 50% patient only present with the hypokalemia. But if if this patient has been treated by the diuretics, then hypokalemia will be the most common, and aldosterone receptors are more present on the cardiac side also. So this patient may have more cardiac complication than the normal patient. So there are the more complication than the normal essential hypertension one. So this thing we have to monitor, and treatment option is a surgery. So now we will move towards the another entity, which is the very interesting entity, which is the glucocorticoid remediable aldosteronism. In cortisol secretion has been controlled by ACTH, because promoter for cortisol secretion is controlled by the ACTH, and while aldosterone is only controlled by 5 to 10% by ACTH. So in the normally in our body, aldosterone is not controlled by ACTH. But in this particular entity, what happens? In this particular entity, aldosterone secretion is also controlled by the ACTH. So whenever we have ACTH surge in our body, like in the morning time or in the stress time, that time we have hyperaldosteronism. That time we have hypertension. So in this cause, hyperaldosteronism is caused due to the high ACTH activation. So how to treat this condition? So generally in this condition, we have to block the ACTH secretion. So if we treat this patient with the cortisol, then ACTH will become down, and the finally aldosterone will become down. So there will be the treatment is cortisol treatment, this patient. This is the autosomal dominant condition, and onset start before the 20 year, and there are the more chances of the complication, and this patient may present with the early hemorrhagic strokes. So now we will move towards the CH variety of the hypokalemia, which is the 11 hydroxylase deficiency. In this patient, due to the blockage of the aldosterone production, there will be the no aldosterone, but there will be the excessive DOC production, which is the potent mineralocorticoids. And due to the high androgen production, this girl child may present with the XY DSP, In the newborn periods, because of the high requirement of aldosterone, this patient may present with the transient salt wasting and hypertension afterwards, and diagnosis has been done by a high DOC level, which is more than 18,000 nanogram per deciliter and borderline high 17 OHP. And how to manage this condition? For manage this condition, again, we have to suppress the ACTH. So cortisol should be required to suppress the ACTH. We need to monitor BP, electrolyte, and DOC is important to follow for the follow-up. And for the women, we need to give the antagonist to the aldosterone receptor, which is the spironolactone. For the men, we need to start with the another molecule, which is the eplerenone and the hydrocortisone. Now, second entity is 17 hydroxylase, which is looking like a 11 hydroxylase deficiency. In this patient have similar manifestation. It present with the hypertension and hypokalemia due to the no androgen production. The boy child present with the XY-DSD, and there will be the delayed puberty in the girl. A diagnosis has been done by high DOC level and high corticosterone level. And to manage this condition, we need to start with the aldosterone receptor antagonist, which is the spironolactone in the girl child. And for boy, we need to start the glucocorticoids. And how to monitor this condition? We need to monitor BP and we need to monitor DOC. So now we will move toward another interesting entity, which is the 11 beta HSD2 deficiency. Normally, in our body, there is a two type of the receptor. One is the aldosterone receptor and one is the cortisol receptor. Cortisol concentration is much more higher than the aldosterone. So body try to prevent effect of the cortisol on the aldosterone receptor by help of the 17 beta HSD. What does that mean? That means that body having shield effect of the 11 beta HSD to prevent cortisol to work. But in this particular reason, there will be the defect in the 11 beta HSD. So all the cortisol is working on the aldosterone receptor. So there will be the hypertension and there will be the hypokalemia. And how to diagnose this condition? This condition has been diagnosed by the high urinary cortisol to cortisone ratio, which is more than 5. And this patient may present with a hypokalemic alkalosis. And due to the excessive loss of the calcium, there will be the nephrocalcinosis. And if we don't treat this condition, then this patient may present with the renal failure. And how to treat this condition? We need to again start with the mineralocorticoid blocker, which is the aldosterone antagonist. So if we summarize my previous 3 slides, then 11 beta hydroxylase may present in the girl with the DSD, in the boy with the early puberty, and diagnosis is done by DOC and high 11 DOC level. Similarly, 17 hydroxylase present in the girl with the delayed puberty and in the boy with the DSD, and diagnosis has been done by the high DOC level. And third condition, which we just discussed about the 11 beta hydroxylase deficiency, there will be the no DSD in the girl and boys, but diagnosis has been done by urinary metabolism. So now we will move towards the another entity, which is the Liddle syndrome. What is the meaning of the Liddle syndrome? In the Liddle syndrome, there is the hyperactivation of the ENaC channel. So what ENaC channel do in our body? ENaC channel sodium absorb the sodium and it loses the potassium. So if there will be the hyperactivation, body loses the potassium from the urine. And why it occurred? It occurred due to the low ubiquitin level from the body. So this condition mainly present with the hypokalemia and alkalosis. In this condition, aldosterone is normal. So giving the mineralocorticoid receptor antagonist will not work. So for treating this condition, we need to start this patient with the amiloride. This is the most important identification. So this patient may not respond with the mineralocorticoid antagonist like a spironolactone, and amiloride is only treatment option for this condition. So if it talks about the diuretics, then there are the two main categories. One is the furosemides, which is the loop diuretics, and the second is the thiazides. Both causes the leaking of the sodium and potassium from the body, and it causes the hypovolemia. So as sir discussed earlier, in any cause of the hypokalemia, there will be the collecting dust that absorb the sodium and secrete the potassium from body. So there will be the potassium loss to conserve the sodium. So in this patient, there will be the high urinary sodium and potassium, and there will be the loss of the chloride and potassium from the urine. So there will be the hypokalemia, and there will be the loss of the proton also. So it present with the metabolic alkalosis, and if treatment has remotely started, then the urinary sodium will be normal. So this is the similar condition as we discussed before, like furosemide excess. So in the Bartter syndrome, there is a defective sodium potassium chloride channel. What does that mean? Body is leaking sodium and potassium from the urine, but from the collecting duct, sodium absorbed and potassium loss. So that means that this patient may present with the salt loss with the hypokalemia, and due to the hypovolemia, there will be the activation of the RAS axis, which cause the hypokalemia, and due to the ABP resistance, there will be the hypopolyuria, and there will be the excretion of the all positive ion from the urine, which cause the nephrocalcinosis, low magnesium, high urinary calcium. So it caused the renal complication, and there will be the low calcium and magnesium in the blood. Gentleman syndrome is similar to thiazide use. So it is less prone for the hypovolemia, and it can cause less severe hypokalemia than the Bartter syndrome. But mainly it present with the magnesium loss. So it is a similar condition like hypokalemic alkalosis, low magnesium, and there will be the high excretion of the urinary magnesium. So it is a similar condition like thiazide excess. If we talk about the diuretics, then in the distal RDA, there will be the defect in the acidification. What does that mean? That means that body is not excreting proton from the body. So body, for maintaining the electric gradient, body try to lose all the positive ion from the urine, like potassium, calcium, and all the positive ion. So there will be the reduced H plus excretion from the collecting duct, and there will be the hypokalemia, and there will be the hypotension. So in this condition, if we treat, then after correction of the acidosis, hypokalemia will be the normal. And this condition mainly improve with the treatment. So if we move towards our last etiology, which is the proximal RTA, in this condition, there will be the loss of the bicarbonate from the urine, and it is the hypovolemia. So there will be the activation of the RAS axis, which can cause loss of the potassium from the urine, which present with the hypokalemia. So if I summarize all the etiology, then hypokalemia occur due to the acute causes, which is occurred by the insulin or beta agonist, and diarrhea and the vomiting can cause the main cause of the hypokalemia, which we see in our pediatric OPD. And this proximal RTA, Bartter syndrome, tubulopathy can cause the chronic hypokalemia. So this is understanding etiology is vital for the management perspective. So now we will move towards the next session.
Thanks a lot, Dr. Manoj. And this was a wonderful discussion that you made things very easy in terms of etiology. So if we talk about from a pediatric perspective, I would say the most common causes would be, of course, the gastrointestinal loss, malnutrition, hypomagnesemia. But if you're talking about chronic, we are talking more in terms of RAS abnormalities, more in terms of tubulopathies, more in terms of RTA. So we'll now go forward in terms of assessment and management of hypokalemia. So the three key questions which a pediatrician has to answer in a patient with hypokalemia: is it really hypokalemia? If it is hypokalemia, what is the site of potassium loss? And finally, what is the final cause in that regards? So hypokalemia can present with multiple manifestations, and the major effect of potassium is, of course, on the heart. And we know that if you have severe hypokalemia, it can cause cardiac arrhythmia and sudden death may also happen. There are also effects in terms of muscular functions and renal concentration mechanisms as well. So the most common presentation in terms of renal is in the form of polyuria, because it induces a secondary nephrogenic DI-like scenario. There would be issues with regards to the ECG changes, and if we are not picking it up at the right time, there will of course be arrhythmia which may happen, which may be life-threatening, which may include AV block and even fibrillation in that regards. Now, muscular weakness is a classical presentation. This is very, very common in the form of neck flop, ascending paralysis, and we all know about hypokalemic paralysis, which can cause. Paralytic ileus could also be an important manifestation in that regards. Persistent hypokalemia, hypomagnesemia, and hypophosphatemia can also induce rhabdomyolysis, which we have discussed a lot in the setting of diabetic ketoacidosis, which can be a very significant issue in terms of causing induced renal dysfunction in that regards. Now, very importantly, it's not just the absolute level of potassium, but how rapidly the potassium levels have fallen is also important. So if we now look at the various levels, generally symptoms do not happen before we have levels which are around 3 or below. Polyuria typically happens below 3. If we talk about muscular problem, again, at around 2 to 2.5, you will have weakness, ileus, and spasm. And the ascending paralysis and rhabdomyolysis suggests a very severe form of hypokalemia in the form of 2 millimoles or lower. And cardiac abnormalities, the ECG changes typically from around below 3 in that regard. So generally, if we are identifying potassium not in a routine fashion, it's going to be very, very severely affected in that regards. Now, we also need to understand that the criteria will differ as different ages, particularly for preterm babies who have got a higher level of potassium in that regards. The term neonates, the levels are slightly lower, 3.7. And infants, again, we go back to the 4 criteria in that setting. So we need to use age-specific criteria in that scenario to identify. Very importantly, if you're using a blood gas analyzer, there will be a falsely low level of potassium in the whole blood by 0.4 millimoles per liter, which you have to correct out in that scenario and that regards. Remember, potassium is an intracellular ion. So if you are squeezing the sample, if there is a tourniquet, you will have an intracellular release. If there is a very high cell count like leukocytosis, like leukemia, there can also be a falsely high potassium, which can cause a confusion in that scenario. Now, once we have confirmed that this is hypokalemia, the next big question is, what is the site? Is it gastrointestinal or urinary? Because cellular shift will be happening in a setting of DKA, in the setting of paralysis, in the setting of insulin, a very rapid scenario. So main question is it gastrointestinal or urinary? The key parameters to look there is urinary potassium. As I already mentioned, that if the urinary potassium is less than 20, that is if you have low blood and low urinary potassium, that is a normal response. But if you are persisting to lose potassium in the urine, despite hypokalemia, it indicates a renal loss. The other parameter to look at is urinary potassium to creatinine ratio, which is equivalent to around 15 milliequivalents per gram, which can be the, and importantly, this has to be corrected for the level of urinary output. So urinary potassium is an important investigation which will help us classify a gastrointestinal versus a renal loss in that scenario. Now, once we know the site, the next big question is, what is the cause of hypokalemia? So go for a comprehensive clinical evaluation. If there is significant failure to thrive, think of renal tubular acidosis, tubulopathy, or malnutrition as the primary cause. Hypertension, as Dr. Vibha was talking about, if it's present, it suggests an increased effect of the RAS axis. Intake of drugs which can cause hypokalemia in the form of diuretics, amphotericin B, cisplatin, and risperidone, which is very, very important. DSD, again, as we have discussed earlier, Dr. Manoj talked about, if you have a XX DSD with hypokalemia, think of 11-hydroxylase deficiency. XY DSD with hypokalemia, think of 17-hydroxylase deficiency in that scenario. Take a comprehensive history of diarrhea and vomiting, along with respiratory features, and sometimes thyrotoxicosis can also cause hypokalemia, which we need to be aware of in that regards. So the most important investigation in a child who presents to you with chronic hypokalemia is the blood gas. Anybody who has hypokalemia should have metabolic alkalosis. If you have metabolic acidosis with hypokalemia, you are largely dealing with either a gastrointestinal loss, diarrhea, or a renal tubular acidosis. Rarely this may happen with acetazolamide intake, which effectively causes a sort of a RTA, or if there is a ureterosigmoidostomy. So hypokalemic acidosis, RTA versus GI loss, go ahead with urinary anion gap in that setting. If you have alkalosis, you have got huge number of possibilities. The next step is to look at blood pressure, and then from there, the renin, angiotensin, aldosterone evaluation. Very importantly, sodium levels, if you have both hyponatremia and hypokalemia, you are having a loss of sodium either via the intestine or via the kidney. So tubulopathies or GI loss is what is relevant in that regards. Hypomagnesemia, anybody who has chronic hypokalemia, look at magnesium levels and of course look for renal dysfunction, do a complete renal function test in that regards. Now, once you have metabolic acidosis, as I said, the key differentials are diarrhea versus RTA. And here, what is relevant is the urinary anion gap. So urinary anion gap is the difference between unmeasured negative ion and the unmeasured positive ion, which in turn reflects the difference between sodium, potassium, and chloride. So it's basically urinary sodium plus potassium minus urinary chloride. In diarrhea, when we have a normal process of ammonium production, the ammonium levels will go up. So your unmeasured positive ion will go up. And in this scenario, the anion gap will be reversed. You will have a negative anion gap. So a normal compensatory response to acidosis is to try to excrete the ammonium in the urine, causing a negative anion gap. However, if you have a problem in the tubule itself, this ammonium production is defective, so you will have a positive anion gap or an increased anion gap in that scenario. So a negative anion gap in somebody who has got hypokalemia and acidosis suggests diarrhea, while a positive anion gap in the setting will suggest the possibility of a renal tubular acidosis in that regards. Now, if you have alkalosis, then your differential becomes wide. Then you have to look at the blood pressure. So if you have alkalosis with hypertension, then there are a lot of causes. And in that regards, if your renin is high, this is clearly renal artery stenosis. While if the renin is low, you're talking about low renin states. There you have to look at aldosterone. So high aldosterone, low renin, that is primary hyperaldosteronism. Think of adrenal adenoma, hyperplasia, or glucocorticoid remediable aldosteronism, as Dr. Manoj talked about. If you have low aldosterone and low renin, it basically means that either you have got an alternate form of aldosterone which is working, like DOC, which happens in 11-hydroxylase or 17-hydroxylase deficiency, or there is an apparent mineralocorticoid excess that cortisol is acting on the cortisol receptor, or there is Liddle syndrome or cortisol resistance in that scenario. So a combination of renin and aldosterone in individuals who have hypertensive alkalosis will give you the diagnosis in that perspective. What about those individuals who have alkalosis with a normal blood pressure? In that scenario, of course, you have to rule out the possibility of loss in the form of vomiting, NG aspiration, and diuretic. Once you do that, your major differentials are Bartle and Gentleman syndrome. So here, if you have hypercalciuria and hypermagnesiuria, you're usually dealing with Bartter syndrome in that regards. If you have Gentleman syndrome, you will have hypocalciuria, but your urinary magnesium will be high. If everything is low, your magnesium is low, urinary magnesium is low, urinary calcium is low, you are dealing with a primary hypomagnesemia, usually because of a malnutrition in that perspective. So as we discussed, in a child who has hypokalemia, acidosis, alkalosis will be the first thing to look at. If there is alkalosis, look at blood pressure. Blood pressure is high, look at renin and aldosterone. Blood pressure is normal, look at urinary calcium and magnesium, which will give you a diagnosis. So if we now summarize the entire disease classification, if you have a association with hypomagnesemia, think of diuretic use, malnutrition, Barters and Gentleman. There will also be low volume state with a pH of alkalosis in that regards. RAS excess will have hypertension. So hypertension with hypokalemia, of course, means RAS excess. Then you have to work up in that perspective. While if you have acidosis along with hypokalemia, you're dealing with either renal tubular acidosis or diarrhea. So the most important investigation to me is to look at the pH, look at the blood pressure, look at magnesium. This will give you the diagnosis very clearly. So the approach to hypokalemia is to first exclude diarrhea, diuretic use, or malnutrition. Then do a blood gas. If blood gas shows acidosis, look at a urinary anion gap. If urinary anion gap is positive, it means that there is an impaired ammonium production, suggesting the diagnosis of a renal tubular acidosis. If it's negative, we are talking about a gastrointestinal loss. If, on the other hand, if you have alkalosis, look at blood pressure. If blood pressure is low, you have to look at low or normal, look at urinary calcium. Urinary calcium is high. This is Bartter syndrome. Urinary calcium is low. It's Gentleman syndrome. But remember, do a fractional excretion of magnesium out here. If, on the other hand, your blood pressure is high, look at aldosterone. High aldosterone means primary hyperaldosteronism. Go for imaging. Think of a familial cause. If the aldosterone is low, look at deoxycorticosterone. If that level is high, this is a CAH variant, 11 or 17 hydroxyl deficiency. If it's normal, look at a spironolactone response. If it's present, this suggests an apparent mineralocorticoid excess. If it's absent, this is Little syndrome. So essentially, the major approach relies on the looking of blood gas, and then based upon that, if there is acidosis, classifying diarrhea versus RTA using a urinary anion gap. If there is alkalosis, look at blood pressure. If blood pressure is low or normal, exclude Bartter versus Gentleman. If the blood pressure is high, classify using aldosterone levels, DOC levels, and the aldosterone response into the various causes of lower renin hypertension, which we'll discuss in much more detail subsequently in further modules in that scenario. So now we'll go on to cases. 2-month-old boy with failure to thrive and hypokalemia. Now, what we do here is look at blood gas. There is acidosis. So hypokalemia with acidosis. This is an important finding. The next question is, what's the anion gap? This is a normal anion gap acidosis. So what do we do here? We look at the urinary anion gap. And in this scenario, we find that the urinary sodium plus potassium is much lower than chloride. So you have a negative urinary anion gap. This is suggestive of a diarrheal loss. So very importantly, if you have hypokalemia and acidosis, do a urinary anion gap. 12-year-old girl with multiple fractures, and we can see severe bone disease, failure to thrive, polyuria, and myopathy. There is significant acidosis and hypokalemia. So acidosis, hypokalemia, failure to thrive, fractures, diagnosis is already made, but we'll go to other investigations. There is a normal anion gap. The blood gas showed acidosis. Urinary anion gap is positive. So this is RTA. And this is a classical presentation of distal RTA in that regards, which was confirmed by a alkaline urine. So acidic blood, alkaline urine, problem in acidification. This is distal RTA written all over in that scenario. 3-month-old girl with significant failure to thrive and hypokalemia. Birth weight was 2,800 and only gained 700 grams since then. There is a significant alkalosis on blood gas examination. pH is 7.54. The blood pressure is normal for the age. So now we are talking about alkalosis with normal blood pressure. Now, if we talk about very early onset, our differences are limited. We are thinking of Bartter syndrome as a possibility. So look at urinary calcium. It is very, very high. It goes more in favor of Bartter syndrome. There was also nephrocalcinosis, which was there. Treatment is with indomethacin, which is going to be effective in that regard. A 2-year-old boy with failure to thrive. There is significant hypokalemia and failure to thrive. Again, the blood gas is showing that there is alkalosis. So this is an older child, older than the Bartter one, which we saw. The blood pressure is normal. There is no hypocalcemia, hypercalciuria. So diagnosis of hypomagnesemia was made because magnesium was low. And somebody thought this could be Gentleman syndrome. So this is the index case where we highlighted that if you have hypomagnesemia with metabolic alkalosis, failure to thrive, always exclude malnutrition and primary hypomagnesemia. So we did a fractional excretion of magnesium, which was low, confirming that this was more like malnutrition rather than other causes in that scenario. 9-year-old boy with leg cramps. So the presentation here is different. And this presentation will tell you what is the most likely diagnosis. The child has significant hypokalemia. And when we did a blood gas, it showed metabolic alkalosis with a normal blood pressure. So again, we are dealing towards the Bartter versus Gentleman. Later presentation with leg cramps goes more in favor of Gentleman syndrome than other scenario. There is hypocalciuria and the magnesium is low. Fe magnesium is high. So this is classically Gentleman syndrome. Think Gentleman syndrome in an older individual with milder presentation with cramps, polyuria. And if you have hypokalemic alkalosis with hypocalciuria and hypermagnesiuria, so essentially just like what the thiazide diuretic does in that scenario. 8-year-old boy with early puberty, height is 134, stage 4 pubic hair development, hypokalemia. The blood gas showed alkalosis. So again, hypokalemic alkalosis, there is hypertension. So this now is towards the right hand of the extreme. We have hypertensive alkalosis with hypokalemia. We need to look for the various aldosterone excess or apparent aldosterone excess like scenario. But the presentation is a clue. There is early puberty. Early puberty in a boy with hypertension, hypokalemia, alkalosis suggests 11-hydroxylase deficiency. So aldosterone was undetectable. There was interestingly cryptorchidism. So this was even more interesting. So this is 11-hydroxylase deficiency in an XX individual who has now been reared as a male because of extreme level of virilization. 14-year-old girl with delayed puberty, height is 148, stage 1 pubic hair development, potassium is low. Blood gas again shows metabolic alkalosis, so hypokalemic alkalosis. There is hypertension. So again, we're dealing with a RAS excess scenario. In this scenario, aldosterone is undetectable. So we have some other cause of RAS excess. Again, delayed puberty, sexual infantilism, hypertension, hypokalemia, direct diagnosis, 17-hydroxylase deficiency. So we thought of that, but interestingly, there was also an inguinal gonad. So this is a mirror image of the previous case, which was XX individual presenting as a male with precocious puberty. Here you have a XY individual presenting as a female with delayed puberty. So looking at puberty, looking at DSD becomes important in hypokalemia, especially if it is chronic. So this is 17-hydroxylase deficiency is an XY DSD in that scenario. 1-year-old boy with failure to thrive and hypokalemia, the blood gas shows metabolic alkalosis, the blood pressure is on the higher side. So again, early onset hypertensive hypokalemia and alkalosis, aldosterone level is undetectable. So we're talking about something else which is acting here. So in this scenario, the DOC is also normal. There is no atypical genitalia. Our differential is Liddle syndrome versus apparent mineralocorticoid excess. And as discussed, we can do genetic studies, but a therapeutic trial to spironolactone will give us a clue. So this child responded to spironolactone, indicating that this was apparent mineralocorticoid excess in that scenario. So a systematic evaluation for blood gas, blood pressure, aldosterone is pretty much sufficient to give us the diagnosis in this scenario. 2-year-old girl with failure to thrive and hypokalemia. Here the blood gas again is showing alkalosis. Blood pressure is again high. Now the aldosterone is again undetectable. We are seeing DOC level is low. So again, a similar case as the previous one. Again, there is no response to spironolactone. So this suggests that this is an epithelial sodium chloride channel. Because it's distal to the spironolactone, there will be no response. Amiloride is what the response will be there. And this is Liddle syndrome in that scenario, what we're looking at. Now, what about management? Management of hypokalemia is not challenging. Acute treatment is indicated only if you have paralysis, arrhythmia, or significant hypokalemia below 2.5. In that scenario, you can use potassium chloride, 0.5 to 1 millimoles per liter. Aim to rise only by 0.3 to 0.5. So you don't want to increase it very rapidly. If possible, go for an oral correction. If there is no indication for acute treatment, if your potassium is less than 3, start oral potassium. More than 3, you can simply supplement with other parameters and correct the cause in that scenario. In general, oral treatment is preferred because if you give too much potassium, it may have a cardiac issue. Avoid dextrose-containing fluid because that will cause insulin release and that will cause shift of potassium. If you're giving potassium more than 40, you use central line, and magnesium is required if there is a refractory case. The preparations include potassium chloride, which provides a rapid correction. Potassium phosphate is particularly beneficial in Fanconi syndrome and diabetic ketoacidosis, and potassium acetate, especially in DKA, to avoid hyperchloremic metabolic acidosis. For RTA, you have got the potassium citrate, which is quite used. Specifically, if you have RTA, you can use bicarbonate and potassium. For malnutrition, magnesium becomes important because that's an important cause here. And if there is an effective hypovolemia, give diamoxin potassium chloride, which will be of effect. And if there's a RAS excess, think of spironolactone. If there is Bartle or Gentleman, indomethacin or amiloride. And if you're thinking of Liddle syndrome, you can use amiloride again. So now we will move forward. We have tried to cover a lot of ground with regards to potassium. We started off with pathophysiology. We then moved forward with regards to the etiology, the evaluation approach, and the management. So now, if there are any questions, you can all feel free to put on the chat box. We will answer that once we are ending the session. And Dr. Vibha will now start talking about the questions which can come and how we can go in that regard. So you also feel free to write on the chat box also in that regard. So Dr. Vibha, please go ahead.
Okay, thank you, sir. After having a wonderful discussion by Dr. Anurag and my colleague Dr. Manoj, and sir has covered a lot of questions, so it will be a quick revision. So the first question is, a 5-year-old child was brought to emergency room after experiencing multiple bouts of vomiting and abdominal pain over the previous 2 to 3 days. So the first question is, what would you get in electrolyte parameters? So kindly write your answer in the chat box. And
yeah, so kindly put on the chat box so that we know it's been interactive. So what are the electrolyte parameters you will expect? Vibha, what will you expect?
So there will be metabolic alkalosis with hypokalemia, as there will be as there is a loss of gastric acid in the form of vomiting, and there is a loss of volume also. It will activate. And sorry, and the next question is explanation of this electrolyte disturbance. So kindly write the answer, please.
So I think people are writing in the Q&A. Hypokalemia, metabolic alkalosis. Dr. Dhwani is writing. Dr. Rajiv is asking in hypokalemia. This is question which we'll discuss later on. So hypokalemia. So what is the cause of hypokalemia here? Is it just the loss of potassium, Dr. Manoj, or is it something else?
So the cause of the hypokalemia is not directly, it is by the alkalosis, and due to the volume loss, it caused the RAS excess, and by that there will be the hypokalemia.
So very good. So carry on, Dr. Vibha.
Now the second question, a 10-year-old boy was admitted to PICU with the chief complaints of polyuria for 15 days and fever, vomiting and abdominal pain for 3 days. On examination, we found he had a mild dehydration and respiratory distress. His RBS was 450 and his blood ketones were 5.5, and his ECG showed the prominent U waves. So I think the diagnosis is quite clear, but the question is not the diagnosis. The question is, what is the most likely electrolyte abnormality present in this case?
So I think we can ask the audience to ask about this answer.
So kindly write the answer.
So you can use the chat box or the Q&A. So this child clearly is DKA. And you are saying that there is a specific finding on ECG, which is there, which is a direct clue for diagnosis. So this seems to have hypokalemia in that setting. So what is the significance of hypokalemia, Dr. Vibha, at diagnosis of DKA? Will you be worried about this child?
Definitely, sir, because if there is a hypokalemia at the time of the admission, so we have to be very cautious about the starting dose of the insulin, and we should delay the insulin for like 1 to 2 hours. Definitely, we don't start the insulin at the treatment, and we also start the potassium in the hydration fluid.
This is very important. As Dr. Vidhu has already mentioned, this is DKA and hypokalemia. So we have to be very cautious in this scenario. We have to give potassium 20 millimoles per liter right in the first hydration fluid that you're giving. And then you also need to be very, very cautious in terms of deferring insulin. So carry on, Dr. Vibha.
Second question, at what level of electrolytes does the U wave appear on the ECG?
So I think that's an interesting question. Let's see if the audience was listening to the discussion or not. So maybe you can just put in on the chat box or Q&A.
Okay.
So just hold on. Let them answer, I think. So less than 2.5, Dr. Dhwani, less than 2, Dr. Vidhu. Which one is correct according to you?
So less than 2.5 it is.
So at less than 3, generally nothing much happens, but 2.5 you start having these problems. Of course, as the severity progresses, you will have the other variations will become more prominent. So this means that there is severe hypokalemia. Yeah.
And the next question is, how will you do the correction in the hypokalemia with the potassium of 2.5?
So this we have discussed. You will probably have to not give insulin. You have to give in the hydration phase. And this is unusual, but then you have to treat it accordingly.
Yes, definitely. Now moving to the next question. A 2-month-old boy with a failure to thrive, weighing 3 kg, and was admitted to PICU with the complaints of loose motion for 5 to 6 days. And he has hypotonia on examination. And his sodium was 139 and potassium was 2.8. And chloride was 112, pH 7.16, and bicarbonate was 14. So the question is, what should be the next step in this case?
So if I just summarize, you have a child who has diarrhea and who has presented with hypokalemia with acidosis. What's the anion gap?
So we have to calculate. This is the question. What is the what should be the next step?
So people can come up with an anion gap.
Yeah.
So anybody can write the anion gap here. So it's sodium minus potassium minus sodium minus chloride minus bicarbonate. So that will be 139 minus 126. That will be 13.
13.
So 13 will be, Dr. Manoj, normal or low or high?
Sir, 13 will be the normal for this patient.
So we have a child who has hypokalemia with acidosis. So what are the 4 differentials, Dr. Manoj, you will think of here?
So a hypokalemia with the metabolic acidosis, first really would be come in the mind is that diarrhea. Second would be the RTA. Third is the treated with the ureterosegmentoscopy. And fourth will be the DKA.
So pretty much diarrhea was the RTA, and often RTA can also have these loose motions which may persist. So that's a confusion between these two. So what will be the next step? I think the audience can just answer this question.
And the diagnosis already you have discussed it. So that was the next question.
So I think this is
now this is the question. How would you distinguish the causes? Like after calculating the NI and what will you do next to distinguish the causes?
So basically what Dr. Vibha is asking is, how do you differentiate diarrhea versus RTA? And that we discussed very, very carefully and discussed. So hopefully, so we'll talk about normal anion gap, GI cause. Okay, would you look at anion gap in some other fluid as well? So we are talking about blood anion gap, which is normal. What about the urinary anion gap? So Dr. Manoj, what do you expect the urinary anion gap if it's diarrhea in this case?
So now, after this blood anion gap, we have to move towards the urinary anion gap. In the diarrhea, it should be the less, or in that RTA, there will be the high urinary anion gap because there will be the defective production of the ammonia. So in the diarrhea, there will be the production of the ammonia is normal. So urinary anion gap will be the normal. In the RTA, it will be the high.
So normal response, Dr. Vibha, in acidosis is what in terms of the anion gap, urinary anion gap?
So normal response, basically in the acidosis, the body has to has to excrete the acid.
Yes.
And the potassium
ammonium production will
be more in the form of ammonia. Exactly.
Yeah, and urinary anion gap will become
positive. Sorry, negative. It is negative.
So negative anion gap will really give you the right diagnosis in this scenario. Yeah, carry forward. Next.
The next question, a 4-month-old boy with a failure to thrive and hypokalemia of 2.6. On examination, he had normal blood pressure. And the VBG showed metabolic alkalosis 7.54 and bicarbonate of 33. So the question is, what should be the next step? If we go according to this algorithm, so what should be the next step after getting the normal blood pressure?
So this is an important scenario of chronic hypokalemia with normal blood pressure, and there is a alkalosis which is there. So Dr. Vibha, what do you think is the most likely diagnosis at a 4-month of age?
So in the 4-month of age, the most likely diagnosis of the normal blood pressure, that it would be if we don't do the next step, so that would be Bartter syndrome.
So Barter will be the most likely because the onset is very early. Gentleman is too early to present like this. So Dr. Vidu has already said urinary calcium. So this is an important investigation. So urinary calcium would be done, which will tell you. So carry forward from there.
And so how would you interpret the result of urinary calcium?
So urinary calcium was high. So this was suggestive of a Barter syndrome, hypercalciuria.
What is gentleman? And what is the preferred treatment for the disorder with nephrocalcinosis?
Okay. So anybody would like to volunteer? Indomethacin. Indomethacin is an important treatment with regards to hypokalemia. Dr. Manoj, anything specific for nephrocalcinosis?
Yeah, we have to start the amylorides in this particular case. And for the preventing, we can start the thiazides also.
Yeah, so thiazide will be a preferable drug in this scenario. So endomethacin with thiazide will be there. So very interesting case there, Dr. Vibha. Carry forward.
It will be going to be very quick.
So this is to be, so we will see who is answering first. So this is like more like a fastest finger first. So those who put the numbers first, we'll stop there. So first question, you can start asking one by one.
Every 0.1 increase in pH, potassium falls by?
Yes,
so you have to give the number. Has answered. How much?
Okay, next.
Who has
Condition
answered?
Rajiv Das has answered.
0.4.
Condition with hypokalemia and metabolic acidosis.
Hold on. 0.4 or 0.6? What is the right answer?
That is 0.6.
0.6. So for every 0.1 change in the pH, potassium usually changes by 0.6. But we will give 0.4 also. 0.6 is the more appropriate answer. So go slowly. Yeah.
Okay.
Second.
Condition with hypokalemia and metabolic acidosis. Two conditions.
So, Dr. Dhwani has already said diarrhea and RTA. So perfect. Yeah.
Perfect. Sodium potassium ATPase pump is activated by?
By mean what? By mean some biological agent?
By any pharmacological agent or by?
Okay. So anybody? It is inhibited by digoxin. We know. So it is activated by? Anybody has a correct answer? Insulin?
Definitely, sir.
Yeah. Carry forward. Dr. Rajiv gave the right answer.
In GRA, that is glucocorticoid.
So GRA is glucocorticoid remediable aldosteronism. Yeah.
Dash gene is switched by dash G.
Yeah. So Dr. Manoj talked a lot about this condition. Very interesting condition. Glucocorticoid remediable aldosteronism. You have hypertension, which is autosomal dominant. And there is a regulation of the production of aldosterone by ACTH and not by the renin. So this is a switch of CYP11B1 with CYP11B2, which is basically there. So this is an important condition to look at. Next.
Diagnosis of AME.
So what is the AME?
That is apparent mineralocorticoid excess is established by?
So you want, of course, genetic will be the answer, which is obvious. What else do you want? Any clinical response to a drug? So Dr. Dhwani said response to aldactone. Absolutely correct. So if you respond to aldactone, you will get the diagnosis. Yeah.
This enzyme 11 beta HSG2, sorry, it converts dash to dash.
So what is the initial product and what is the final product? So Dr. Manoj talked about 11 beta HSG2 as a shield which is there for the mineralocorticoid tissues. So mineralocorticoid tissues, basically, they prevent them from hyperactivity of an agent which is 100 times or 1000 times more in concentration in the blood, which is, so anybody can write the answer quickly, cortisol to cortisone.
Yeah.
True? Correct? So this basically inactivates the cortisol to cortisone. Dr. Rajiv Das has given the right answer. So Dr. Rajiv and Dr. Dhani are the most highest in terms of the scores. Next time we'll do a quiz also probably in this format. It will be easier.
The cause of Liddle syndrome is?
So I think this is a very simple question. The cause of Liddle syndrome is ENaC defect. Dr. Dhwani has mentioned again. So correct.
Okay. The sodium chloride symporter defect causes?
Which syndrome? So sodium chloride symporter defect. Now, if I ask about activating or inactivating?
Sir, it is definitely inactivating.
So if you have activating mutation, what will you have?
Sir, this is
So
Gordon.
this is gentleman syndrome here. Otherwise, it will be the Gordon syndrome.
Gordon.
So again, Dr. Dhani has got it right. So I think any further questions, or we have
There
finished?
is one. A
Yeah,
condition
last.
with high renin and high aldosterone.
So high renin, high aldosterone.
Generally, we get low renin and high aldosterone. So there is a condition that causes high renin and high aldosterone.
So Dr. Rajiv has mentioned RAS, so renal artery stenosis.
Yeah,
Correct?
definitely. So
So
the last question, condition with hyponatremia and hypokalemia.
yes.
Any
So
condition, yeah.
hyponatremia, hypokalemia, both are losing from
Yes, both are losing.
furosemide, true. Diuretic use,
Tubulopathia, yeah.
tubulopathies,
Yes, sir.
gastrointestinal loss. Dr. Dhani again, right. So I
Definitely.
think Dr. Dhani has just scored more than Dr. Rajiv, but both had very good competitive this thing. So I think this
Thank you,
was
sir.
very interesting format, Dr. Vibha, and we will carry forward for other programs as well. So we will now be looking for if there are any particular questions to answer that. I think there was a question by Dr. Rajiv about in case of hypokalemia in an infant with severe diarrhea and moderate dehydration, whether Potlur can be given with fruit juice or alone. So if you have significant hypokalemia and the child is accepting orally, you can give Potlur. I think that's a good option. Oral is always preferred, and you can give with fruit juice also. There's no problem. Potlur alone may also be effective. But if you have severe changes like ECG changes, if you have features of paralysis, then you might have to think of whether IV treatment is required there or not. Dr. Rajiv is asking, in a male patient with AME, can decadron or amiloride be given on a long-term basis, as spironolactone may cause gynecomastia? Dr. Manoj, what do you think? So in heparin middlecorticoid excess, we said, okay, spironolactone is a good agent, but then it can cause anti-androgen.
Anti-androgen.
Which agent will you prefer?
So we have to start that molecule which don't have effect on the androgen, which don't act as an androgen antagonist. So eplerenone in this condition will be the option. So we have
what
to
about
treat this
decadron? How do you think? Decadron is going to cause a lot of side effects. So dexamethasone, of course, is not something which we will prefer in this scenario. And the use of steroids in this scenario is anyway a debatable thing in that regard. You're basically suppressing the production of cortisol. Amiloride can be given, but in our experience, the amiloride response is not as good as the response of middlecorticoid antagonists. So better would be to use eplerenone if you are concerned about gynecomastia in that scenario. So I think this was a very, very interesting discussion. So we tried to cover a lot about hypokalemia in terms of pathophysiology, in terms of etiology, in terms of evaluation and management. And very interesting OSCE and questions were put up by Dr. Vibha. So once again, thanks all of you for joining from across the globe at this time, because usually we have it on Saturdays. This time we had to do it on Sunday. So still a lot of people have joined in. Thanks, Dr. Manoj and Dr. Vibha, for all the efforts you've put in. And next month, we'll continue with our module. So we have covered in electrolytes, hypokalemia, hyponatremia, and hypernatremia. Next time, we'll probably switch over to hypomagnesemia as an interesting scenario, and we'll go forward from there. So thanks all of you.